Thank you, everyone, for joining us for another Learning Lunch hosted by FormatApproved.com. My name is Brian Johnson. I'm the Senior Director of Online Education with Format Approved, and I'll be your moderator today. Today's Learning Lunch title is The EMR Mandate and 2014 MU Deadline Penalty. We're joined today by Joy Rios of Format Approved. Joy is an expert in both meaningful use and EHR proficiency with years of real-world experience in meaningful use attestation and EHR implementation and optimization. Joy has a unique talent for taking difficult material such as meaningful use and explaining it in straightforward terms. Let's glance at the questions for today's session while I go over some quick housekeeping notes. Remember that you can ask questions of our presenter at any time during today's session by entering them into the chat area. In the second half of our presentation, we'll address as many questions as time allows. If we do run out of time, answers to all submitted questions will be posted to our website and sent via email link later in the week. Also, remember that all registered attendees of today's session, whether they're able to join us now or not, will receive an email with links to both the slides and the recorded version of the event. So we often get questions about the slides. Rest assured that you'll get those in our follow-up email. All right, Joy, well, thank you for joining us as always. These are very popular sessions. There's so much interest in meaningful use now, and it's great to be able to share your expertise.
Thanks for having me. I always am happy to share the things that I learn along the way, that's for sure.
All right, let's get into it then. So, 2014 is a big year in so many different ways. What can providers attest for this year?
So this year, folks can be attesting and submitting information for 2 programs. Well, technically 3. The meaningful use, the EHR program for both Medicare and Medicaid. Right now, both Medicare and Medicaid are accepting attestations for the 2013 reporting year. So depending on what year you are in, if you're in if you're in the first year, that would have been a 90-day reporting period. If you were in your second year of attestation for either program, that would be a full year reporting period, so January to December. And there are some states, California is one of them, that they had some grace periods for the previous year. So for 2000, they're still accepting information for 2012. Reporting period. And that goes all the way until March 31st, at least in California, and I know that there's a couple other states that are in the same process. And then additionally, there's the PQRS program. So that has kind of gone under the radar for some folks, but yeah, that's the other program that's accepting submissions, and it's their quality reporting program. And in order to receive the incentive, you would have to submit information on 3 different quality measures to earn 0.5% reimbursement on Medicare Part B charges. And if you're only interested in avoiding the penalty, you would need to submit 1 quality measure to avoid a negative payment adjustment of 1.5% that would be applied to 2015 Medicare Part B reimbursements. As of today, there are technically 3 different ways that you can submit that PQRS information. CMS is accepting claims data from last year up until Friday, and same with but those claims would have had to have been marked kind of as they go, as they were encountered. So it's not a situation where you can go back and resubmit claims that have already been submitted. So just want to make that clarification. And then registries, they have an extended deadline. So if you haven't submitted PQRS data and you haven't gone through that process, the qualified registries have until March 31st to submit that information. So you get a little bit of extra time. They kind of have a pre-deadline too, which is, I think it's March 11th. So if you haven't started that process and you want to avoid that penalty, I recommend getting in touch. Probably the best way would be going through a qualified registry and making sure that you submit at the very minimum at least 1 quality measure by March 11th so that you can avoid that penalty. And then of course there's also the EHR. So under the EHR, there's 3 different ways to submit, and those deadlines are all this Friday too. So it would be, if you happen to be using an EHR that is qualified to submit directly to CMS, if you signed up to do the alignment of the, use the program pilot that aligns both meaningful use measure, quality measures, and the PQRS, or if you enlist an EHR data submission vendor who would submit that information. They'd pull it out of your EHR and then submit it to CMS on your behalf. So
well,
there's plenty to think about.
Our focus here is on meaningful use, but I'm glad you touched on PQRS. Somebody in the audience already asked, well, what is this PQRS she's talking about? That's the Physician Quality Reporting System. And the reason why I think it's good that we've at least touched on it here before we focus a little more narrowly on MU, although we're going to touch on PQRS here and there as we go through, is that these programs began as very distinct programs, but they're sort of merging. Well, they're not merging, not yet anyway, but they're moving in the same direction. So PQRS is very like the clinical quality measures and meaningful use. And so the in fact, you can participate in 2 programs through a pilot. You can participate them through one reporting. So that I think we're going to hear more and more about MU and PQRS sort of becoming very much parallel programs.
That's right. There's a lot of overlap between the 2. So for the clinical quality measures for 2013, there were 44 approved measures that you can report on, and you need those, the 3 core measures and then 3 additional measures for a total of 6. And then the PQRS program, up until this year, you only needed to report 3 in order to earn that incentive. And it's been a voluntary program since 2006, and it's this year, the 2013 reporting year, that is starting the penalties. So I think that that's part of the reason why we're hearing more about it, because the 2 have a lot of overlap. They're trying to get more alignment between them, and then both of them have penalties associated with it. So.
Yeah, and it's kind of surprising how many people really don't know that much about PQRS, considering the fact that, well, to be honest, when the penalties first hit and they see that entry on their reimbursements, I think it's really going to be surprising for a lot of people.
Certainly, yep.
Okay, well, let's get to MU then. What does the Medicare EHR deadline extension mean for practices? And just in case anybody didn't hear, I guess we start with, what was the deadline extension again?
So the original deadline for the original deadline for Medicare EHR was February 28th. That would have been 2 days from now. And this year they had such an overwhelming participation rate that they decided they wanted to make sure that every hospital and every EP that wanted to attest had the opportunity to do so. So they extended that deadline to March 31st. So we have a full extra month to submit attestation data. But what that means is the criteria still must have been met from the 2013 reporting period. So they're not accepting any information after, that was input into the EHR after December 31st of last year. But it does give more time for providers to receive, to register and attest so that they can receive the incentive, but also it gives them more time to avoid that penalty. And this is certainly a one-time opportunity. It's not something that I imagine they're going to do again and again. So apparently they've had such overwhelming participation. They've had as many as 7,000 people and providers attest in just 1 day. So it's certainly not recommended to wait until the last minute. Don't wait to get started because there's an extra deadline. Get started as soon as possible. And, of course, it doesn't affect the Medicaid portion of the EHR. So the Medicaid EHR programs are run by each state, and they have their own deadlines. So if you're participating in the Medicaid side, make sure that you're following the deadline for your state, not the Medicare federal program.
Okay, and so just to amplify this point, I guess, this doesn't affect the actual data you're reporting on. It just you can't, catch up on 2013 by suddenly keeping reporting going or something. All it means is that you have more time to report on the data you should have already collected for 2013.
That's correct.
So let's get into some nitty-gritty here. What do providers need to complete an attestation?
So if you're ready to submit your attestation, if you've collected all your information, you're going to need the meaningful use report from your EHR for each one of the measures. So for eligible professionals, that's 13 core measures and 5 menu measures. And if you have any exclusions, so for if some reason some of the measures don't apply to you, you need documentation for that explains why it doesn't why you don't need to submit that. There is a really useful tool here, and that's why I've included this link. CMS has a calculator that's it's actually 100% risk-free. You can go through and take your report and submit your numerators and denominators and see how you would do before, see if you would be successful or fail an attestation if you were to go through the real thing. So it's kind of a practice run. I highly recommend getting familiar with it, because what they do is they simulate the attestation process pretty much screenshot by, screen by screen. So you get a really good feel of what it looks like to go through that attestation process.
I'd just like to interject here that we've truncated, unfortunately CMS, all of their URLs are this, 50 lines long. So we've truncated that to a link, but keep your eyes open for the slide versions of this, because you'll be able to click on the link and get it.
Perfect. And with and additionally, you'll need the information about your clinical quality measures from your report. So typically that's a different reporting module. So you may have your meaningful use dashboard that tells you all of your core and menu objectives. And then in addition to that, you would be able to get the report that has all the clinical quality measures. And each EHR, in order to be certified, will provide information for a minimum of 9 clinical quality measures. You're going to need to report a total of 6 in order, so making sure that you either got your 3 core or 3 alternate core measures, and then in addition to that, 3 more. There's one measure that doesn't require information from the EHR at all, and that's the HIPAA or the security risk analysis. So that's not information that you would spit out of a report. That would be something that you had completed last year. You need the documentation that says you've gone through the process of making sure that you've checked your technology and have all your BAA signs and are in compliance with HIPAA. Another thing that has been helpful for providers is making sure that you have screenshots of certain order types. So for the computerized provider order entry pieces, if you've ordered any labs, take a screenshot of those, and also of your patient reminders. That's one, just so that you can keep it in a file for later, that if you were to get audited, it's good to have those as backup. And then, of course, for any exclusions that you are submitting, make sure that you have some sort of documentation that proves that you qualify. So, for example, if you are excluded from the e-prescribe module or e-prescribe measure because you don't prescribe at least 100 medications per year, then you need to be able to say, you should be able to create a report that says, okay, well, I only prescribed 99 this last year, so therefore I'm excluded. Or if you only, if it's 5, whatever it is, have that information kept. And make sure that you keep all of that for a total of 6 years in the case that you get audited. And then another thing to think about is those public health measures. So there are 2 public health measures that are included in the menu objectives, and it's submitting to the immunization registry or submitting information to the syndromic surveillance registry. And you're supposed to only be able to exclude one of those. The caveat is if your region is unable to accept electronic submissions from your EHR, then you can have an exclusion to both of those. But you need if for some reason that they cannot accept that information electronically, then it's good to keep that as documentation too. If you can get a letter from them that confirms that, so that you have that in your back pocket in case CMS comes asking about why you chose that as an exclusion.
So what else do providers need to complete an attestation, Joy?
Sure, this is more of the nitty-gritty stuff. So you're going to, like, as you go through the process, you're going to need the EHR certification number. That's not something that you typically know by heart. It's about a 10 or 12-digit number. And the same place that you go and you look up to see if you're, what type of certification your EHR has, which everybody should be doing, to be checking that list on the see if their EHR is certified for the 2014 standards. That's the same website that you would go and you would find your product, find your EHR product, whether it's complete, modular, whatever the technology is, and you essentially, you click the button that says add it to cart. You're not purchasing it there, but the process of adding it to the cart opens up a window that gives you that certification number, and you'll need to use that certification number, and if it actually just print that screen, and you can upload that with your attestation. If you're submitting if you're participating in the Medicaid side, you're going to need the Identity and Access Management Systems account. Sometimes it's the IACS. I don't know if they've changed the acronym this year, but that's what you would use. It's like step one in the process. And in addition to registering and testing with the federal program, that's how you register for the Medicaid. And I've also included here the link. So when we send out this presentation, for if you don't have the EHR, the federal program registration and attestation site, it's included here. And then also the state contacts, so you can find your state and see the website where you can follow instructions that are specific to your area.
So what are some other deadlines and penalties that providers need to keep in mind?
So we're going back to the PQRS. This is something that sounds like some folks have just kind of let slip because it hasn't been the top priority. Meaningful use has certainly been up there as far as things to talk about. So PQRS has some deadlines for this Friday. Again, the last day to submit your 2013 data through the EHR reporting methods, and those are the qualified EHRs, or if you have an EHR data submission vendor, or also if you're participating in the pilot program. Friday's the last day to do that. If you are participating in a pilot program, the way that you identify or nominate that is it's through the meaningful use attestation. So on the federal website, when you sign up and you go through the process, there's one question, I think it's like the third or fourth question in, that asks you, it's a yes or no question. Are you participating in the PQRS Medicare EHR incentive pilot? And you would have to mark yes in that area in order to participate in the program, and then follow the instructions for submitting both your CQM and PQRS data. And the benefit of doing that is that you kill two birds with one stone. You're submitting the quality measures for both programs in one go. And another thing to remember is that if you do choose to go that way, in that method, then your meaningful use attestation is not complete until you have submitted your PQRS data. And then this is also the last day to submit the claims data for the PQRS program, and then again, I'm kind of reiterating that March 31st you have a little bit extra time to submit information on the report for the qualified registries. So both programs, it's a big week. If you haven't prepared, the next couple of days might be pretty busy for you.
So what happens now? We're really at the stage where incentives are giving way to penalties. What's going to happen for those providers who haven't done anything up to this point on meaningful use and on PQRS?
Oh, so if you've done absolutely nothing and you don't plan on doing anything, you're not going to see anything happen this year, but you will next year. So in 2015, you'll see a negative 1% for the EHR program, and then you'll see a negative 1.5% for PQRS penalty. So that's all, it's all negative payment adjustments for your Medicare Part B reimbursements. And if you're part of a group that is large, there's the value-based. If you have 100 or more eligible professionals that are part of your group practice, there's an additional 1% penalty that is applied. It's called the value-based modifier. So it does, 1% in and of itself may not seem like so much, but I'm sure that the combination of them could be a big hit next year. And then those increase year after year. So in 2016, the EHR penalty increases to 2%, and so does the PQRS penalty. So it would be, excuse me, 2% for each, plus an additional, I think, 1%. So close, a negative 5% penalty.
Yeah,
in 2000.
Eventually the meaningful use penalties rise just on themselves to 5%. And, there's also some tricky things here, like the value-based modifier program, if I'm recalling this correctly. Right now it's only for groups of 100 or more EPs, but if I remember it, next year it goes to, is it 10 or more? And it keeps growing so that more and more people are basically included in the VBM.
Yeah, that's right. So next year they are lowering the threshold, and they anticipate that it could go as though not in 2015, but potentially by, I think, 2017, that even individual providers could be hit without additional penalty.
That's their goal, is to eventually extend that out to everybody, basically.
Yeah, that's right. That's right.
And somebody just asked this. It's, we'll address this real quick. 5% of what number? We're talking about Medicare reimbursements. This is Part B only? Am I correct in that?
I believe, yeah, that's correct, Part B. And Medicaid is not subject to penalties. So if you do take, if you take both Medicare and Medicaid patients, you will see a penalty on your Medicare, but not on the Medicaid. And in fact, for the entire EHR incentive program, there's no penalty whatsoever on the Medicaid side of things, unless it's something that's driven by the state, which I haven't seen anything yet as far as what those are.
All right, so here we are in 2014. Stage 2 has arrived, at least for many people. What should providers be thinking about as they try to get ready for Stage 2?
So, okay, we've talked about what you can attest for right now, and going forward, the number one thing that you're going to need to think about is your EHR and whether it meets the 2014 edition certification, because it doesn't matter, no matter what stage you are in, even if it's your very first year of meaningful use, they have changed the requirements that the certified EHR technology must meet the 2014 standards. So the same place that you would have gone to find that long digit number to find your certification number is where you would also be able to see where if your EHR meets those standards. Take into consideration a couple things about that. Right now there's like 120 EHR products that are certified out of something like 1,000 that were certified for the previous, the 2011 edition. There is a huge queue as far as products getting in line to get certified. So there's a big number of people that are currently in the process and are hoping to get it done, with either in the first quarter or the second quarter of this year, so that their clients can continue using their product and also attest this year for meaningful use.
And to be clear, this is the main reason why the reporting period for 2014, regardless of what you're doing, whether you're on Stage 2 or not, is a quarter. My understanding is that the main reason why is that the EHRs themselves, there's so many of them that need to certify, that getting them ready in time just wasn't going to happen.
Yeah, that's right. And then one of the certifying bodies decided that they don't want in the business anymore. So I think there used to be 3 certifying bodies that were going through all of the EHR vendors' information, and now that's been reduced to 2. So if the line has gotten even longer, which is unfortunate. But stage 2. So one of the biggest things, and if you don't hear about it every single day, you're going to just keep hearing about it more and more. And interoperability is the key word, and it's showing up in a couple places, quite a few places. One is in the patient engagement piece, and that is where they've changed the wordings where patients need to have timely access and be able to view, download, and transmit their health information. So if you're in stage 1, you need to, typically that's done through a patient portal or a patient health record, or, that's sort of been the way the things have been going. So your EHR would connect to a patient portal, and then the patient would be able to log into that portal and either view it online, download their health record, and then be able to transmit it, so essentially take it with them to another doctor. So this is a lot of transitions of care, referring doctors from their primary care physician to a specialty care provider, all of those. They need a safe, secure method of being able to share information. The other aspect of patient engagement that is included in stage 2 is the secure messaging. So patients need to have an ability to message their providers and ask them about certain types of health questions about their care. And then also with stage 2, there's we've seen the interfacing and connecting with pharmacies and being able to electronically prescribe, but now there is a new push to be able to interface with labs and radiology centers to be able to share those types of imaging results and tests and whatnot, so that they can directly be, so that you can see the results transferred, in a structured way, not just a picture of like a PDF or a JPEG or something. So they're trying to be able to truly, truly exchange information. And so with that comes different types, we're seeing new acronyms show up. The newest one for stage 2 is called the CCDA, and it's the Consolidated Clinical Document Architecture, and that is the format in which information is created so that all the EHRs can either export it or import it in the same format, and then it can kind of be sent off to the different buckets that it needs to go in, so that it can be readable by both a computer and by a human.
So folks who have been out of the loop for a while may know CCR in this context, not Clearwater Revival, and then CCD, and now we're on CCDA.
Yeah, more alphabet soup. And then, so for folks that are in stage 1, they need to be able to offer that capability of offering the secure messaging and offering the view, download, transmit. But folks in stage 2 are getting they're getting measured on whether or not they're actually able to engage their patients in those activities. So the first part is setting up the system so that it exists, and then the second stage is whether or not that is being, the system is being used. So folks that are in their 3rd or 4th year of attesting, depending on, or of submitting their attestation or participating in the program, they will be required to get 5% of their patients to perform these actions, to log in, to check out their health information, to take it to their doctor, or to send a message to their doctor. So there's certainly challenges ahead.
Well, there's challenges, but let's talk about some of the tools that can help providers meet some of these challenges.
Sure. It's pretty cool what's going on. People are making some amazing efforts. And one has been around for a while, or it's not too long, but long enough, and it's this, the key about it is the interoperability. It's called the Direct Project. So I've listed the website here where you can read all about it, but what it does is it supports common scenarios where, say, one person or an organization needs to send clinical information to another person or another organization, which is the whole point of interoperability, and to being able to do that securely. So there is a tool out there, and it's essentially, I think the way it's going to show up is as a subscription email account, where for say $10, I don't know if it's $10 a month or something like that, providers can get a particular email account, and it uses this CCDA format, and it's very secure and safe, and all of these different organizations, the health information exchanges and different EHR products and other technologies, labs, there's a ton of organizations that are signing up because it's essentially the connector. It's the missing link, I guess, if you will, so that if anybody that has an email address can submit information securely to any of those organizations that are participating. So that is something that is in the works, that is being created, and I think that will help providers and companies just kind of be speaking the same language, which is definitely needed. And then secondly, there is a new tool that was just announced a couple weeks ago. I haven't seen anybody use it, but it's specifically for Measure 3, which is that requires at least one summary of care document to be sent electronically to a recipient of a different EHR vendor or to a CMS test vendor. So we've heard that, like, okay, in order to meet the requirement, you need to be able to, send a patient record to another provider that doesn't use the same system that you do. And this EHR randomizer, when you sign up and register, it pretty much helps you do that. It walks you through the steps. So it allows hospitals and professionals to exchange data with a test EHR, and it helps them meet that measure, the third measure of stage 2, and requires them to conduct one or more successful electronic exchange of a summary of care, or with a test EHR. So to use the tool to meet this measure, you just register with the EHR randomizer, and once you register, it pairs your EHR technology with a different test EHR from the list of authorized systems, and then you send one of your consolidated clinical care architecture doc summaries, the CCDA record, to that test. So two things need to be in place. One, you need to have an EHR that can create a CCDA document, and then two, you need to register with this randomizer. I believe that this tool is free. Additionally, the HIMSS announced, there's, HIMSS is going on right now in Orlando, so there's a lot of big announcements, and I wasn't able to add this onto the slide. But it looks like coming soon, providers are going to be able to have access to a downloadable security risk assessment tool that should help them meet that last requirement of meaningful use that isn't associated or doesn't come directly from an EHR. So I don't know what that's going to look like yet, but it sounds interesting.
So stage 3 got pushed back a year, but it's still on the horizon. And of course, this is exciting to think about where meaningful use is ultimately headed. What's in store for stage 3? I know there's a little bit more information than there used to be.
Yeah, so we know that they're looking at improved outcomes, and now they're starting to drill down in ways that we might get there, and above and beyond just quality measures. So stage 3 has been set to now start in 2017. It was originally going to be set to be released in 2016. A couple of things that they have proposed to put on as new objectives. One is order tracking, and this would require providers to assist with follow-up on the orders to improve the management and coordination of results. So essentially, the documentation and tests from specialty consults would need to be returned to the provider that ordered them, and then it would need to display any abnormal test results with the dates that it was completed and dates when the data was viewed by specific clinicians. So it would require a higher, high degree of effort from providers, but their intention is that it's not just the ability to create an order within your EHR, but offering the ability to be able to just track that order so that you can follow a patient and make sure that they're taking actions to improve results. This one is kind of interesting. There's unique device identifiers that have been put on the list of things that they're potentially including in stage 3. So anything that is implantable or in the human body, they're trying to do this to better track patient safety. So if there's any product recalls or any adverse events or any types of complications, they want to be able to create a structured list of, okay, who does this affect, and let's go find those people so they can have quicker addressing of care. We've seen patient-generated health data. So anybody who wears one of those Fitbits or Up bracelets that tracks their their walking and their steps, their pedometers, all that, or even their blood pressure, anything, all of that information that patients are tracking on their own. It's possible that we're going to see that information be included and populated by the patient into a patient portal so that it can be tracked and pulled into the EHR as necessary. We'll see how that plays out. And then there's additional requirements to report adverse events to the Federal Drug Administration and then also the CDC. So I imagine that those are specifically for the public health measures or additional public health measures like the cancer registries. And then a couple other things that I have seen show up as recommendations are care planning. So it could be a menu measure for providers that patients that are older than 65, they must have an advance directive recorded in the EHR, that type of thing. So we'll see. It's definitely going down to, not just the ability to take action. And now we've created, there's a lot of follow-up included in the stage 3 proposal. So we'll see how it turns out.
All right, so Congress is working on aligning some of these initiatives, and we've talked a little bit about how PQRS and EHR are sort of drawing closer together. Looking really beyond MU, what are we looking at in terms of the program sort of all coming together? Tell us a little bit about what might be on the horizon for that.
Yeah, it's so interesting. There's so much going on, and there's so many different programs. I think that CMS and everyone in the industry is starting to realize that there needs to be a little bit more alignment. So that would include the, information from the Accountable Care Act, meaningful use, all the ICD-10 stuff, and value-based purchasing. CMS is looking for ways that they can align it. So there's been some ideas that have been proposed to Congress. One, which I find particularly interesting, is called MIPS. Here we go with a new acronym. And it is the Merit-Based Incentive Payment System. And what they are proposing is that would be something that shows up in 2018. So this would be right after stage 3. I think that, if who knows, if you get stage 3 from in 2017 and then this new alignment program comes through in 2018, it could be very interesting. So what it would do, what they're proposing, is that it would streamline the PQRS program, the value-based payment modifier program, and the EHR incentive program into one incentive program that would provide both positive and negative payment adjustments based on the EP's overall performance in 4 categories. So they would be looking at quality, so the quality measures, the resources that are used, so they'd be looking at how many tests are ordered, and for example, are the appropriate amount of tests being ordered, the meaningful use of an EHR, and then also the clinical practice improvement activities. So I think that kind of comes in with those surveys and the patient experience. So what I have read is that in 2018, the providers could earn a positive payment adjustment, this is crazy, as high as 12%, and as low as, or as a negative payment adjustment as low as 4%. And then they're looking at increasing that. By 2021, the incentive could be as high as 27%, and the negative adjustment could be as low as 9%. So they're looking at some really, this would be a true pay-for-performance program, really. And it's going to be interesting to see how it plays out. But right now, that's what's on the table.
Yeah, and so it's really, with the Accountable Care Act, you've got sort of the first little hints of pay-for-performance, and that's in the value-based modifier program, where they're looking at both the quality of care but also the cost of providing that care. But you can see that this is sort of where they want to go.
Yeah, and it looks like if this law passes, they say the bonuses would max out at 3 times the penalties, and the law would award an additional $500 million per year from 2018 to 2023 to exceptional performers. So folks, it sounds like the people that are really gung-ho and making a point to keep up with this pace of change could get rewarded significantly, which that's great news.
Well, anything else we need to touch on here before we start taking some questions from our audience?
I think that just to acknowledge that the bar is really high, and there's a lot of hard work that people are putting in, and it's a collaborative effort, and hopefully at the end of it all, it's worth it. So I think that we're in a really unique place, and this industry is kind of hopefully filled with optimists, where we're in a position that what we're doing is going to enhance the quality and efficiency of care and reduce the cost of care that we provide, hopefully.
All right, well, let's get to some questions from our audience. We have quite a few questions, so we'll answer as many of those as time allows. And you can see here some links we've provided. We'll talk about those at the end of our session, but do feel free to type in these URLs as we talk if you're interested in any of the offerings. Okay, so we talked about what PQRS is. So let's see. It says, I believe that last year we were able to file PQRS along with our manual attestation. Is this the same? Do we need to have been notifying someone, CMS, on these measures during 2013?
So it depends on how you would have been, how you choose to report. This is one thing that CMS has, I don't know, for better or for worse, for 2013, there were 13 different ways that you could report PQRS measures. So that ranges from, coding your claims differently and submitting information on your claims, either electronic or paper, going through one of those qualified registries, or if you have an EHR, or getting the information directly from your EHR, and then also groups, which is providers of two or more providers that have the same tax ID number. They could have self-elected or registered to use the group practice reporting option, but the deadline for participating in that method passed in October. It was like October 15th. So it really depends. If you chose to submit that data via claims, it's something that you would have been doing all year long. If you're submitting it via registry or EHR, it's something that you would be doing pretty much right now. EHR, again, the deadline is to submit that information would be the 28th. And then if you're interested in a little bit more time to participate through the registry, their deadline is March 31st. So if there is still time to participate in that program, and what it would require would be, creating a list or a filtered list of those measures from your EHR, and then carving out the Medicare Part B patients, and then walking through to the registry. I would recommend getting in touch with a qualified registry, because they would be able to really drill down and give you specific information about exactly what they need and in what time frame, and kind of get you there, so that at the very minimum you could avoid the penalty for 2015.
Here we have a question from an IT consultant who says, 2 of my clients are small doctor's offices. One of them has done almost nothing so far. Is there any way they can qualify for any reimbursements?
The thing that they could possibly do, if they wanted to participate in the Medicaid EHR incentive program, the Medicaid program does not require that providers meet meaningful use in the first year. So the first year of submission would be they have two eligibility requirements that they would need to meet. One is that they have a 30% threshold of Medicaid patients if they don't have for a 90-day period. So you'd have to look somewhere within their schedule and look for, okay, have 30% of their patients coming in on Medicaid insurance, and get them involved in a certified EHR. If they have a certified EHR, then they've qualified for adopting, and that's what's required for the Medicaid program. For year 1 of that program, you don't need to meet meaningful use. You can adopt, implement, or upgrade a certified EHR technology. So adopting it would just, to be honest, there are some free ones out there that if they're in a position that they don't want to spend the money, they can sign up for a free EHR, meet their 30% threshold, and then take that incentive money and invest it in something that would be good for their practice. Potentially, that's one option.
Here's a question about PQRS and behavioral health, and I think it's kind of interesting. The question is, we're behavioral health, and several of our providers only see patients under 18. There are really not enough measures for behavioral health to choose in the first place, but you add the fact that those that are available don't apply to patients under 18, and that causes us not to be pulling the numbers. I can't find exclusions for PQRS. Are there any? So, it's just to add my own comment before you answer, there's something like 256 measures or something in PQRS. So there's a lot of measures, and they're trying to hit everybody. But I don't know, there's cases where there may not be measures that are really applicable.
Yeah, that's possible. But I think that they've tried to open them. The fact that there's 258 to choose from, it could be as simple as the tobacco one. Have you asked the patients whether or not they smoke, and that's included, the tobacco cessation, or even the calculating the patient's BMI. There's 2 right there. That if you include information on those ones, which are pretty common in most EHRs, you should be able to pull that information out. That would, at the very minimum, at least allow you to avoid the penalty. And if you go ahead.
So you may not be, using the measures group, but you should be able to sort of pick and choose individual measures to be able to meet the requirement.
Especially for 2013. So for 2013, for the PQRS in particular, you only need to submit information on 3 quality measures. That changes altogether in 2014 and they've added additional. Not only have they increased it from 3 to 9, but they've added an additional filter that those 9 must cover at least 3 of the national quality strategy domains. So you can't just pick any 9. They have to be 9 of a certain type. and that's why they've CMS has introduced the adult recommended set. There's 9 recommended quality measures for the adult population and 9 recommended measures for the pediatric population. And that would be a good place to at least start and see if those ones meet your needs. And that's, I'm talking about for 2014. For 2013, of the 258, just pick 3. And you don't have to worry about if they meet any particular domain.
Yeah, so just as with meaningful use, PQRS is going through some pretty significant changes in 2014 with more required measures, and they have to be a little bit more diverse than they might have been in the past. Here's a question about public health. We are a specialty that does not give immunizations, nor do we collect syndromic surveillance data. Does that alone give us exclusions in both of the public health measures?
They said it was, as of last year, this is kind of a tricky area, that you would not be able to submit, that you would not be able to claim an exclusion to both public health measures. And then they've added the information for 2014. It says, if you're prohibited, if you're not able to, if that registry or agency is unable to collect data. Now, what they're really looking for is if you're not in a position that you're taking or giving immunizations or taking syndromic surveillance information, talk to your EHR vendor, because what they're looking for is a test submission. They're looking for the capability. Have you gone through the motions of trying to figure out if you can actually submit information in the case that you would need to? So even if you have no information to submit, you could meet the qualification by, testing the capability of those 2 agencies talking to each other. Again, that's like an interoperability conversation. That's where it's showing up. Do you have anything to add to that, Brian? Am I missing anything?
No, I think that's a good explanation. We have a question here that I think is really a great one. I do want to address this briefly before I hand it off to you. The question is, what if a practice or hospital is changing EMR vendors this year? And I think that, the surveys show that it may be as high as 70% or something, that lots of providers, after getting their EHRs early on especially, are now that they have, we're headed into stage 2 here, they've reached the point where they'd like to change out their EHR. And this is a great year to do that, because it doesn't really matter what stage you're in or what you're doing. You only have to report on a quarter for meaningful use. So, if you do want to change your EHR, this is a great opportunity for you to go in, really select carefully, which EHR you want to use, go through all of the headache and work of getting it changed over, and then be ready in time to still do your reporting. So I think this is a great opportunity to do that. And Joy, I'll hand it off to you now.
I think you're absolutely right. And if you are in a position that you're going to be switching EHRs, make sure that you may be in a position that you're, as you transition, you're using both for a small period of time. That's going to be a little bit of a headache, I'm sure. But whatever information that is included in your previous or original EHR, make sure that you can, if you can export the data, or if there's a way that you can capture the information that's in there, because remember, you are responsible for keep holding on to your meaningful use attestation information for a total of 6 years. So if you transition, find out how you can keep that information in your back pocket, so that should you need it later to be able to prove, that it was used in a meaningful way, that you have that information.
That's a great point. And if you go to the Format Approved Marketplace, we've got some folks there who specialize in this. There's a lot of different options for how you can keep that data. So, you need to migrate that data one way or another. Some people just have it essentially as an archive, but other people, you're able to integrate all of your previous data into the new system. But don't assume that the EHR is just going to do it for you, because they typically do not. The EHRs are not really, don't necessarily work together in terms of data. So do look into that as an important thing to consider as you're exploring a new EHR. Someone's asked about the CCDA. Can you tell us just a little bit more of what that is and why it's important as we're heading into stage 2?
Sure. Let me see what I can. It is, so it used to be that when you're going to export data, right? So a patient comes in, they come in for their visit, and you would be creating a CCR, so a consolidated care record, and then that transitioned over to a CCD as a consolidated care document. And the way that that looks, it's they use a styling format to create a document architecture. And the best way that I just can describe it is that it looks like a very specific Excel document. So if you're familiar with, each cell would have a specific assignment to it. So it would have your patient name, first name, last name, middle name, demographic information, and then would also include their history of vitals, their care plan, their progress notes, their each summary, and it's all as structured data. So each point of information has a very specific cell that it is assigned to. And the reason they created that way is so that it is agnostic, so that if all vendors are using this particular architecture styling or format, language, I guess, then if you create that kind of document from one, you can pull that same information into another. So I think that they're just advancing and becoming more specific about what that architecture looks like, and we're in the next level of that evolution.
All right, well, we got to a lot of questions. We didn't quite get to all of them, but rest assured that we'll send out written responses to those questions, and we'll share those answers with everyone in case some of you have the same questions, although, of course, we won't share who asked, so don't worry about that. Remember that all registered attendees of this event will receive an email with links to both the slides and the video recording of this session, so you'll have a chance to review the information, and those links we talked about, you'll be able to click on those and actually get the resources we talked about here. Remember that you must have a risk analysis to attest for meaningful use, and ForMed Approved is here to help. Visit www.formedservices.com to see our risk analysis offerings, including special value bundles around meaningful use attestation. If you want a deeper understanding of meaningful use, visit formedtraining.com to take our Certified Meaningful Use Professional course. That course covers both Stage 1 and Stage 2 for both eligible professionals and eligible hospitals. Be sure to read Joy's regular industry column for ForMed Approved called Ask Joy. You can click on the link on the screen there when you get the slides, or visit formedapproved.com/hitanswers/author/joyr. Thank you, Joy, for joining us. It's always a pleasure to have you with us, and thank you to the audience for joining us.
Thanks for having me. Again, I'm happy to help and contribute.
All right. Well, to our audience, please join us for our future learning lunches. Visit formedapproved.com to learn about our upcoming learning lunches. These are always free to the public. The Learning Lunch button will take you to our upcoming webinars where you can learn more and register. Our next Learning Lunch will air March 6th and has the title, Population Health Can Improve Practice Profitability. So that'll be an interesting subject. Keep an eye on our email box and our homepage for other upcoming topics, and thank you again for joining us today.